I think the next area that I want to sort of explore with everybody is this concept of data. And I believe right now, as we have healthcare reform, it's no longer, I think, appropriate to say, well, you need to come to me because I'm such a good urologist, because that's who I am. I trained here, I did this. I think all of us are going to be, we should be tracking outcomes, tracking metrics, tracking data. As we've all said, data is the new currency. So I think one of the opportunities that we have, especially those of us in larger groups, as part of a very large group organization, is how can we as groups, how can we as practices, all dedicated to the advancement of better management of urology patients, how can group collaborative efforts promote quality through clinical outcomes, through initiatives such as pathway development and data integration? So, Neil, you're the current secretary of LUGPA, and I know you're heavy into research and really are a believer of integration and data integration. Tell us a little bit what's happening at the LUGPA level, at the AUA level, those types of things.
Great. So thanks for that question. We've got two great projects ongoing right now at LUGPA. About over a year ago, we started a data integration project, and we're going to be rolling out some phenomenal data aggregation, as you said, so that our own groups can see where they can reflect in terms of their clinical pathways, how they're utilizing their employees, how they're utilizing their partners, patient visits, use of resources. So that's our data project, and that's finally coming to complete fruition this year, and we'll have that presented. The other project that we're doing right now, and we received the largest grant to date at LUGPA from Genomic Health, is for our benchmarking committee. And our benchmarking committee, led by Phil Buffington at Gary's group and Jeremy Shelton at Skyline Urology, we've looked now at our retrospective active surveillance data, contemporaneous data right now, and I'm very excited that they're going to be presenting that information of our contemporaneous active surveillance rates, and then we're going to do a large prospective registry. So to your point, we're going to now be able to say, what are we doing? We can look at ourselves as a big, large organization, as well as individual practice can say, how do I stand up? And then within your own practice, you could look at your own individual utilization, because as you state very clearly, the data really tells the story. The data tells the story in terms of quality and value as opposed to volume, which we're clearly moving away from. So I think at this year's meeting, I'm extremely excited, and we'll have that presented to our membership.
Gary, you want to add on to that? I mean, Phil's very involved, obviously, and you will be our president-elect. So how does this look for the next couple of years moving forward?
Well, I mean, I can't add much more to what Neil said. These are two critical projects for LUGPA. Look, LUGPA has only been in existence for 5 or 6 years, which if you look back over the history, it's absolutely incredible the impact that we've had as an organization on the landscape of urology. We all know we've had an impact in terms of political advocacy and so forth. That's not our focus today. The amazing impact that we're beginning to have in urology is on the practice of urology, integrating pathways, integrating new services that help the patient, as we've been talking about today. And thankfully, because of the asset that we have in someone like Neil, we're starting to really push the boundaries of science with respect to large urology group practice. In his active surveillance project, we'll be able to define what the active surveillance rate is in large urology groups. Large urology groups provide a huge percentage of the care in America to the urologic patient. And through projects like this, we'll be able to positively impact their care. So very proud of what LUGPA is doing.
Yeah, the only thing I'd like to add to Neil's comments, which I think we're spot on, is just that these are benchmarks that all allow us to improve. And I think if we can look at our colleagues and we can see whether our active surveillance rate doesn't meet this benchmark or anything else we're doing, that we're an overutilizer perhaps compared to everybody else, it makes us look at our own practice, and I think it gives us all the ability to improve. And I think that's really the importance of all this, is that it's really self-improvement, so we all can get to a higher level.
I clearly believe that the more data as we hopefully try to standardize some things. I mean, we've looked at the LUGPA data as it relates to complications after biopsies. We've looked at the standardization of the number of cores that are taken at the time of biopsy. I think there are tremendous opportunities, and this goes across every disease state in urology, whether it be cancer-related, whether it be incontinence, those types of things. I think the ability to capture large volumes of data. Historically, the capture database, which was started by the folks that used to be TAP Pharmaceuticals and was really pioneered by Peter Carroll's group over at UCSF, created a tremendous amount of abstracts just with the ability to put in data from individual practitioners across the United States. Now, you can argue that database was a little bit skewed and there was maybe not so much standardization, but they generated a tremendous amount of abstracts from a very simple database. We all know that many of the companies that are actively engaged and have serious interest in the management of CRPC are setting up registry trials. We know that the Dendreon people supported the PROCEED registry. They were a little bit mandated because the FDA wanted them to look at the incidence of cerebrovascular accidents on patients that got subpulous LT. But again, we're starting to see the effects of those 2,000 patients, and again, a number of abstracts are coming forth from that PROCEED database. And I think you're also going to see this because, again, many of these companies are going to adopt that model.
Raul, can I follow up on one thing
Sure.
that Richard said, if I may? And because I agree with him 100%, and I think we need to emphasize this. In the new healthcare paradigm, we cannot act as physicians as silos. We can't act as silos in our own groups. And furthermore, we can't act as silos as LUGPA groups around the country. And to your point, we need data in order to benchmark both practice performance and clinical performance of individual physicians within a group and between groups in order to elevate our care, provide more cost-effective quality care. And LUGPA's ability to take the lead on providing these benchmarks will really allow us to do that.
And Raul, let me add to that because Gary, that's a great point. And my focus, I think the initiatives of LUGPA have been great. But for us as a group, ours is on quality, the individual physician quality care to that patient. And I believe, and nobody take offense to this, but I just do not think it is what it can be. When we look at the data that tells us that patients who are on ADT suppression, all of those patients should basically be on calcium and vitamin D. And we know when you look at the data, it's about 20% across the country. So anybody tells me that they're providing superior care, I question that. So how can we fix that? So we are working with a company now that is going to put the evidence-based protocols in front of the doctor. If the physician has to go to their cell phone, take out their cell phone, unlock the cell phone, pull up an app, open the app, put it, they're not going to do it. If we put any more burden on the physician, they're not going to do it. So we are looking at initiatives now that put the protocol right in front of the patient. The doctor. When the doctor has his computer open, at the same time that EMR history is there, in the corner is going to be the protocol that pops up on the screen. So it's right there in front of them. We will be able to know if the doctor looks at it, follows it, and does it. So for us, it's going to be how are we going to be able to provide the patient with the best quality care. And I think moving forward, as many of you have said, we are going to be judged on that quality of care. And I think that right now we're just judged on what bills we submit. We need to be judged on the care that we give and the quality and the outcomes that the patient have. The only way we're going to do that, I believe, is we follow the best of our ability, evidence-based decision making.
Can I ask you a question about that, if it's okay, Raul? So this idea of the protocol popping up in front of the physician for XYZ diagnosis, I intellectually I get that. My concern about that, let me give you a little pushback, is on protocol screen fatigue. just sort of like you have to override when you're prescribing medications, and everyone's ignoring that, and they're overriding on their prescriptions. And it's kind of a truism, isn't it? I get it intellectually, but where do you put that in terms of the issue of making sure, rather than having a protocol pop up de rigueur, you basically say, we're no longer having everybody see this patient, that instead it's going to the specialist within your group, so that that specialist has it burned into his frontal lobe. He doesn't need the pop-up. So that's sort of the interesting tension that we're facing now in our large groups, isn't it?
Yeah, but when you're talking about large groups, 35, 56, 30, 40, whatever it is. But in groups that have 7 or 5 or 10, they don't have that fellowship or expert trained in every practice. And remember, LUGPA represents groups of all sizes from 5 to 105. And so we want to make, my hope is that it's available to everybody.
Yep.
And yes, we do have that specialist, and Gary, I hope we get to talk about, what Gary's done on the so-called ADT clinic, or advanced prostate cancer clinics, that he's developed over there. But this is something that every physician should be able to use, because there's just too much information out there, Neil, as you know. When I began practice 30 years ago, there were a few antibiotics. There was DES to treat prostate cancer, and nothing for ED. Now there's more drugs for ED than I think I had to know when I came out in training. There's too much information out there. Doctors can't process it all and know it all, and this is maybe an avenue that we'll be able to do it. We know the oncologists were very successful in that, and they also got a huge increase in their reimbursement when they followed protocols.